Good evening, everyone. Welcome to the fifth episode of Focal Point. We're still admitting the last few people who are coming, so as soon as that slows down a little bit, we will get started. I'm so glad everybody could join us. My name is Janelle Collins, and I'm your host for tonight. I serve as the member at large on the board of directors of ANA, and I live in Florida in the United States with my husband and my two children. My awesome 16-year-old daughter has Aniridia. Our episode tonight is focused on the aniridic cornea, and specifically, we're going to talk tonight about treatments. Our guest for tonight is Dr. Albert Cheung, and I'm going to go ahead and read his bio because, as usual, I did not get a chance to memorize this whole thing. So, Dr. Cheung is part of the skilled cornea team at Virginia Eye Consultants in Norfolk, Virginia. He joined VEC to provide a world-class corneal and cataract care to patients. He offers advanced medical and surgical options for corneal diseases such as keratoconus, severe ocular surface disease, including things like aniridic keratopathy. He is also part of the community faculty in the ophthalmology department at Eastern Virginia Medical School at Old Dominion University, where Dr. Peter Netland is chair. Dr. Cheung has given national and international lectures on various corneal and cataract topics. As a researcher, I understand he has authored more than 120 peer-reviewed journal articles and book chapters. And additionally, he has presented numerous papers, abstracts, and posters at national meetings. His research focus has encompassed lamellar corneal transplantation, limbal stem cell deficiency, ocular surface stem cell transplantation, and cataract outcomes. Dr. Cheung completed a cornea and external disease fellowship at Cincinnati Eye Institute under Dr. Edward Holland, which is a name a lot of you recognize. And he's currently working with the Holland Foundation for Sight Restoration to establish a center of excellence for the treatment of severe ocular surface failure. Now, since I haven't had the honor of seeing Dr. Cheung as a clinician, I asked Michael Shane, who is ANA's newest board member, for his recent experiences. He said Dr. Cheung was very thorough with his initial evaluation and his presentation of my procedure. He discussed the potential upsides as well as the potential concerns. He was very generous with his time, his care, and he answered all of my questions. I know that I'm in excellent hands and I'm confident with his guidance. Dr. Cheung, I am so honored that you have joined us here tonight.
Well, thank you so much for having me. Thanks for the kind introduction. It's a pleasure to be here and talk to you all.
Yeah, we're so glad to have you here. Thank you to everybody who is online who submitted questions ahead of time. Some of you submitted them for the last episode, some of you submitted them this time. If you think of more questions as we talk, please don't hesitate to ask them in the chat. We are going to be trying to monitor that as we go here. Let's see here. I would like to show you all something. Since when we discussed this at the last focal point, we said that the cornea is just a really, really complex topic. And because it is such a complex topic, what we see as, I think it's showing the wrong screen, isn't it? Let me see here. Let me just check. What we see as patients is often very different than what what the researchers and clinicians see. We usually only see the very tip of the iceberg here, the stuff that sees the light of day. I'm hoping you all can see my iceberg picture. But in order to get this tip of the iceberg, we have so much under the water that has to happen that iceberg is built on. And so last time we talked with Dr. Freeman just about that very tip. We talked about, an overview of the cornea, an overview of the treatments. Tonight, Dr. Cheung and I are going to talk even more about the clinical care and the treatments, and then also about clinical research and some of the treatments that are coming up. So just know that this is a very deep topic. And so if we don't get to all of your questions tonight, or if your question falls maybe into one of these lower levels, we will do our best to address those in future episodes. So on that note, let's go ahead and get started straight with questions. So Dr. Cheung, even though we did an overview of the last time when we had an episode, there are people here that maybe didn't join us then or haven't watched it. So I was wondering, can you briefly just repeat an overview? What is the cornea and what goes wrong with it in aniridia that requires treatment?
Sure. No, great introduction. Dr. Freeman did a great job. I checked out that webinar podcast as well. The cornea is the clear dome on the front surface of the eye. It helps protect the eye, helps focus light to help you get better vision or to have vision. It has multiple layers, about 5 to 6, depending on what source you use. And the main layer that we're talking about here with aniridic keratopathy is the epithelium, or that skin layer. There are stem cells that line the cornea 360 degrees around. So essentially where the white or the conjunctiva and sclera, so the white part, meet the cornea. That whole way around are the limbal stem cells, and they're responsible for making clear skin over the cornea. When those don't work, so there's deficiency or dysfunction of those, um, you can start to have the conjunctiva grow over the cornea. And so you can start to have haze in that area. It can be irregular, and those things can lead to poor vision. That skin is not very good or stable, and you can have erosions in that area. And also you can have vessels that grow in. Uh, when you have vessels growing, you have a high risk of scarring, sometimes cholesterol deposit in there, and also it can be bad for transplants and have them more likely to reject and fail. So they're high risk transplants for corneal transplants. So when we think about aniridic associated keratopathy, that main reason is that limbal stem cell deficiency. But you can also have poor growth and movement of the corneal skin cells. Uh, the skin cells also don't have good adhesions, so that's how you get the erosions, or might have impaired wound healing, make you at risk for infections. And then there can also be an association with poor nerves in that area as well, leading to type of dryness and things like that. Oftentimes, we'll see this disease or condition go through different stages. It'll start in the periphery of the cornea and then move its way centrally. And we see this with the conjunctival cells, and they stain with the fluorescein. So you often have your doctor put in that yellow dye
Mhm.
and put that blue light over there, and they're looking for a green sort of stipple pattern that denotes and sometimes it's in a whirl-like pattern. So this feathery whirl-like pattern, showing that the conjunctival cells are actually on the cornea itself.
Okay.
Um, as it moves centrally, you get this haze or clouding, vessels grow in, like we talked about from the conjunctiva. As you have poor epithelium or poor skin on the cornea, then you can get sort of fibrosis or scarring in that area. So additional haze, and then it can go deeper and deeper. So that's a pretty good start there.
No, that's a great description of something that's very complex, right? Multifactorial and all kinds of things going on there. All right. Can you give us just a brief overview of the current available treatments? We'll go into them more in depth in a little bit, but if you want to just kind of list off what they are.
Sure. So I like to think about treatments for example, for stem cell deficiency as direct treatments or indirect treatments. And a lot of them will be indirect treatments because you're not replacing the stem cells. There are other systems on the ocular surface, especially we talked about dryness and there's different types of dry eyes and evaporative, so loss of it or deficiency in the water component. So you can often treat, for example, the dryness to try and improve the symptoms from the actual stem cell deficiency, which is the actual underlying issue, right, in aniridic keratopathy. So you might use increased lubrication, especially with preservative-free tears, gels, or ointments. You might try to get more lubrication on the eyes by putting little plugs in the corner of your eyelids to prevent the outflow down to your nose and mouth. That's when you cry, your nose runs. But if we can block that with either a plug, collagen or silicone for those sorts, we can keep more tears on the eye. And you can have upper and lower drains on each eye that you can utilize for that. There are dry eye medications, so prescription dry eye medications. In the U.S., we have a handful of them. A lot of them are cyclosporine, you probably heard of,
Mhm.
which comes in the forms of Restasis, Cequa, and Vivi, for example. Just
Okay.
different percentages of that in different vehicles, so the drop component that they're in. They decrease inflammation on ocular surface to decrease that dry eye cycle. There's some other, your doctor might consider other dry medications like lifitegrast, tacrolimus. Those are other, like I said, drops. But there's also a nose spray called varenicline or Tervea. that can help stimulate a nerve in the nose, help you generate more tears
Interesting.
from a nerve pathway, like a full tear that will hopefully help you keep you more lubricated. If, for example, your lids are an issue, and there was a recent study out from Poland on aniridics that showed a good amount of aniridics have also lid disease, which is a part of dry eyes. You don't have a good oil layer for your tears, and your tears will evaporate too fast.
Okay.
Um, you can help supplement. Well, you can use lid hygiene, so you may consider warm compresses, lid scrubs, or sprays to help improve the oil layer. But then there's also MIBO, which is a semi-fluorinated alkane. So it's an oil-like drop that helps almost supplement that type of oil. People
Oh,
think it feels pretty
interesting.
good. It almost acts as a longer acting tear. It's also the vehicle in Vivae with sort of, well, the semi-fluorinated alkane it's also part of the of Vivae.
Okay.
So combined with the cyclosporine there. Um, a lot of people love serum tears, and I think that Dr. Freeman attested to that. I think it's great for severe dry eyes. That's where they take your blood, take down a blood sample, spin down the blood cells, take out the blood cells, and the fluid that you're left with has a lot of healing factors, anti-inflammatory factors that can be good for the ocular surface. You might have some protective type shielding strategies. So you can, let's say you were having erosions and that was causing pain or risk for infection. You could put a bandaged contact lens, so a medical contact lens, therapeutically to help cover the eye. Also, scleral and prose lenses are amazing. They are hard lenses that fluid layer that sort of so that not only do they protect the cornea and can give you some vision because of the refractive properties, but it leaves a layer of fluid over your cornea that can then treat dryness
Okay.
and the surface. There is anterior lamellar keratoplasty with so a Descemet's membrane anterior keratoplasty or bright mem, which is we'll probably talk about this more later, but a layer of Descemet's membrane that we place on the top that has some proteins on it that might help some skin growth. There are now there are more direct treatments like ocular surface stem cell transplantation, where we're actually replacing stem cells on ocular surface, so it actually treats the underlying stem cell issue. So you have, depending on where you have who's donating the stem cells, you can have a deceased donor, someone who's passed away. That's a keratolimbo allograft. In cases where maybe it's sporadic aniridia, where you have a living relative who who does not have aniridia, or in cases when you have a sibling maybe who or someone else who doesn't have aniridia, they could be a donor with their stem cells, and they can help restore the ocular surface. There are other types of allogeneic CLET and SLET. You might hear of those. Those are different types of modifications on stem cell procedures where they take a small amount of stem cells from a donor, and then they expand them out in the culture, and then or on the ocular surface, and then that helps coat the eye with some better epithelium. You can also take a small amount from the mouth.
Oh,
That's called COMET or cultivated oral mucosal epithelial transplantation. They take the small sample from the mouth. It's actually your own cells, but it's oral mucosal, and they can expand it in a lab, have a sheet of that, and then place that over the ocular surface.
huh.
You're looking through oral mucosa, so it might not be as visually it might not be as clear, but
Okay.
it helps restore the ocular surface in some regards, especially if in some severe forms of stem cell deficiency.
Oh, that makes sense.
And then lastly, I would say that there's also keratoprostheses or K-pros, where they have essentially it's like a corneal transplant where you have that center has a medical grade plastic type optic, so that you look through that and you don't have to worry about rejecting the cornea in that center part, and you would still have a relatively clear optic to look through.
That was a really impressive job of summarizing a lot of really complex things in a very short period of time. That was very impressive. All right, let's discuss a bunch of those things more in depth. But before we do, somebody asked, what is that lid medicine called? The oil that you mentioned?
Oh, MIBO?
Mibo? And how do you spell
Yeah. Uh,
it? Nope.
MIEBO, I believe. I always get the E and
MEIB.
I mixed up.
Okay.
Let
Oral
me just
solid.
double check that really
All right.
fast.
Well, I threw it in here for now and we can look it up
Yes, MEIBO.
okay,
In the
awesome.
United States, it goes, if you're in other countries, so in Europe, it's actually over the counter. It's called Evo tiers, EVO tiers. And then in
Oh, okay.
Australia, I know it's like Nova tiers, NOVA tiers.
Okay, awesome. That's really helpful. I had not heard of that before, so that's extremely cool. All right, so I guess let's start. We are getting a couple of good questions here. Rachel is asking, should we start drops as babies to keep the eye lubricated? She said she's currently giving her 14-month-old sustained drops. Is that a good plan? Should we just do that for every aniridic baby?
So most babies and most young children won't have dry eyes. If they are noting though that there is some keratopathy, if there's some changes from the aniridia on the cornea,
Hmm.
um, it can be helpful,
Okay.
preservative-free tears, especially if it seems like the child is symptomatic. Then that
Okay.
yeah, that's certainly not going to hurt at all. Yeah, and it can be
Okay.
helpful.
Okay. Awesome. All right, so since we're talking about children, let's continue that vein, okay?
Sure.
If a young baby has corneal issues, now most of the time, like the traditional progression would be that they're okay as babies, like you just mentioned, but sometimes we do have ones that are born with significant corneal issues. What is the earliest we can remove the cornea? Danielle from Connecticut asked that.
So that's yeah, great question. I would first like to bring up a great point that Dr. Freeman made, that Dr. Holland has drained or ingrained in all of us as your fellows, that a corneal transplant will not treat a stem cell disease. And so you might hear me talk about this just because that's a good point to make that you can do it if you have a stem cell issue, but you do a corneal transplant, the transplant will invariably fail at some point. Now, it does have the skin, the good skin that the donor had, but that only lasts for about a few months. And then after that, usually the skin cells from the recipient will take over and over the new graft. And then, like we talked about, the stem cell deficiency in general is a risk factor for rejection and failure, and even some non-rejection ways to fail. But then to get back to the question, so in general, if we talk about corneal transplants, I don't think you would need that as a kid, or infant or child, in aniridic keratopathy.
Not typically
Because
anyway, right?
yes, correct. But then to answer the question, can you do it in infancy? Uh, yes, you can. The child would have to undergo general anesthesia to have the transplant, and this is usually for like severe corneal opacities,
Mhm.
where they can't see and they're worried for to have amblyopia, where
Right.
it's a condition where the brain will shut off the eye if there's not a good picture to the brain. So not really, like I said, this is not really for aniridia, but just to answer the question, infants under general anesthesia can have the transplant, and then they have to go back a few weeks later under anesthesia to take out the stitches,
Mhm.
sutures. Success rates can depend largely on some other factors, such as if there's glaucoma or not. Long-term success can, if in the best case scenarios, can be up to 50% in those cases. But if there's poor follow-up, success can be as low as zero. I was talking to one of my, because I was talking to some of my colleagues who do more of these. I actually don't really do many pediatric keratoplasties, but it really takes a motivated family, and it's really the balance if the opacity is really severe.
Yeah, yeah. We see it more in our friends that have, were diagnosed with aniridia, but really it's kind of Axenfeld Rieger. We see it more,
Yep. Yeah,
in
some of
that
these
group.
other congenital.
Yeah, or maybe Wager. Sometimes we see that. So Diana from Alabama asked, would using an allogeneic serum drop be helpful for the cornea as well? We talked about the autologous serum. She said, could it help prevent keratopathy in a young patient, because they would have factors that the aniridic patient lacks, or would that cause inflammation and worsen things since it's not your own stuff?
Yeah, good question. I don't think it would reverse the aniridia because that's
Okay.
more of a genetic and uh, cause, and it's causing the actual stem cell issue. And there's nothing that the factors in your blood worsen anything.
Okay.
Um, in general, we usually typically use regular serum tears from yourself, and I think that that would actually be better in a way. I
Okay.
don't think you have any benefit from getting allogenic
Okay.
tears.
So then Lauren from New York asked, what are some signs that keratopathy is advancing? So like in her case, she has a young child. Early signs showed up on an EUA, but not on a normal ophthalmic exam. What should she be watching for in her child?
Excuse me. Yeah, great question. So typically, it is really tough to see these changes. The late staining that we're talking about, so the conjunctival cells growing over the cornea, uh, they're while they might be a little hazy to many ophthalmologists, they'll be missed. So unless they're very trained at seeing it, I get a lot of referrals for other various, they think they're various things, and then I'll end up saying, oh, that's actually stem cell deficiency. And really, it comes down to when you stain it, just a pattern it looks like. Um, and then, so I guess the question is, how are they looking and seeing if it's worsening? So it's on those examining anesthesias where they're if it's a really young child, where they're able to get a really good look, and then see if it's advancing, especially more centrally, if there's looking for neovascularization and some other areas, other signs of some more central haze. They can do at special centers a good way to check the stem cells is confocal microscopy. It's essentially a live microscope that can look at the stem cell locations as well as the type of cells, skin cells on the cornea, and they can see if there's these mucus producing cells, and that can be a sign that there's actually the conjunctival skin that's on the cornea.
Okay.
Uh, I think that's yeah.
Yeah, no, that's great. Um,
Sorry. Let me just one other thing. You're saying, oh, what's another way you can think of if it's becoming more symptomatic? Really, symptoms from the kid, right? They
mhm,
might be more light sensitive. They might be for the eye might feel more irritated to them, or they might might rub at the area or might seem like it's more irritated. So that might be a more telling sign, especially if than what the child is like showing or exhibiting compared to what the doctor may or may not see.
right. It's interesting that you said that not everybody catches it. We actually had that with my daughter. Nobody had ever seen it. And then we saw Dr. Netland as part of the Adelerin
Hmm.
clinical trial. And he says, yep, sure enough, there's early grade 1 keratopathy in there. And I'm like, oh, you're the first person that's told me that. Went back to my local doctor who's very, very good and actually knows Dr. Netland. And he says, nope, I don't see any of the keratopathy I would expect. And I said, really? Because Dr. Netland said it's there. And he said, oh, let me take another look. And he looked even
Yeah.
closer. And
Hmm.
sure enough, he says, wouldn't have known. So that was an example to me that you do have to have somebody who knows what they're looking for when it's real
It-
early.
yeah, it can be very subtle, especially
Yeah,
the peripheral changes.
yeah. So I found that really fascinating. So Rosina from Texas, and this we've kind of addressed this already, but what is the recommended age to start treating the keratopathy? And I think you kind of answered that by saying, well, we prevent it as much as we can with the lubricating, right? And then we treat it when it becomes a problem. Is that?
Yeah, you're more treating the symptoms exactly.
Mhm.
It's not that I wouldn't say it's preventing it, but it is decreasing the how symptomatic it is when you treat these other systems like the dryness and things like that, or and really the signs of the keratopathy or the stem cell deficiency can act like dryness.
Right, right. That makes sense. All right. So, do you have any experiences or recommendations on scleral lenses for kids who have keratopathy or the Berkasia eye drops? That was asked by Sarah from Ontario.
Sure. Scleral lenses, as I mentioned before, I think are great. They work in multiple ways for anyone with irregular corneas or really dry even really dry corneas or bad ocular surface diseases, anything with some mild scarring, yeah, mild to moderate to scarring where you have irregularity and of the shape of the cornea.
Mhm.
Because if you think about if you just have these hills and valleys over the surface of your cornea, the lens vaults over those hills and valleys, fills those hills and valleys with fluid, and you can now focus the light so much better to see better. So it's not only, and then that layer of fluid is also basking it's like a little fishbowl on the surface, and boy,
Right.
the surface loves lubrication. So, and you have that the whole time you have the lens on. So, um, that can be therapeutic in a way as well as visually beneficial.
No.
I don't have much experience with Vercasia. That's 1%, I think, believe cyclosporine. They don't must use it in atopic or a bad allergic disease,
Okay.
maybe vernal. But it be just like the other signs of formulations of cyclosporine. It should be very beneficial in terms of decreasing ocular surface inflammation. I think it would be good because sometimes we compound cyclosporine even up to I believe 2% for some
Oh,
cases.
okay.
Um, and this is available, commercially as 1%. It would some have a benefit.
Okay, that makes sense. So if you had a 10-year-old son with aniridia, what steps would you tell your son to take to minimize or to manage the keratopathy?
I think some of the ways we talked about really increasing sort of lubrication, minimizing any preservatives on the eye that would help that child, in terms of feel better or maybe minimize some of the symptoms. And then uh, other ways would be to use a scleral lens over the eye. If it got really bad in some cases, oh, one thing we forgot to mention was amniotic membrane can be very helpful. Sort of a healing
Mm-hmm.
membrane can um, help some of these skins areas heal or optimize some of the late staining or the conjunctivization areas. So that can be beneficial if early on.
Okay. Um, and then kind of the last one about children, and then I'm going to pick up one from the chat. Is there anything as a parent that we can do to help support a healthy cornea, like diet, food, supplements, anything like that?
There's besides some of the lubricate the ocular surface treatments we mentioned, there's not really things prevent prevent the changes from coming. Um, Not really anything in the diet that I'm aware of, or in terms of supplements. If you're treating dry eyes, there was a study, a dream study, that looked at omega-3, fish oils and olive oil, and found that they both helped, you know,
Hmm.
the evaporative dry eyes. So in terms of some of the factors, so the Mediterranean diet is good for other reasons too. So
Okay, okay, that's helpful. Vassal in the chat asked, what is the probability of keratopathy progressing to the degree that it interferes with vision in a patient with aniridia, like in your average aniridia patient, if such a thing exists?
yeah, I know that. Dr. Freeman, I don't want to contradict anything because I think he did a great job. I think he was saying by age 5, a certain percentage, a small percentage would start to may have some symptoms. I don't know if he said between 10 to 20% or something like that. And then that can increase over time. There are some studies that even like in middle to later age, like 90%, 80 to 90% of patients may have keratopathy. Um, I don't know if I have a great answer for what's the percent of that are severe.
Right, right.
I just off the top of my head, but
Yeah.
we were actually looking at some of that stuff with Dr. Holland in terms of some of the staging and when people are diagnosed or referred compared to when they actually need treatment, what stages and exactly what ages. We started to look at that. So
Okay. So,
maybe we'll have a better
maybe
answer in the future.
and say, yeah, we might have better answers for that in the future. I know that some have also looked at trying to figure out, does it matter what your specific genotype is? So what your mutation is, and does that impact, that kind of stuff. So it hopefully in years future we'll have better answers to some of that.
Yeah.
So moving on, let's talk specifically about each type of treatment a little bit. And we're going to
Okay.
start with the most severe. We're going to start with what you ended with, if that's all right. We'll start with the
Yeah.
K-Pro, the keratoprosthesis or the artificial cornea. Can you tell us more about the current statistical success rate of the K-Pro? And then what are the consequences or potential problems associated when it doesn't work?
Sure. So K-Pro is a relatively straightforward corneal surgery. Most corneal specialists that do corneal transplants would be comfortable in the suturing part of it's very similar to a penetrating keratoplasty, like the full thickness transplant, just has the optic in the middle. It's more or less the follow-up and making sure that you're trying to do everything to prevent adverse events or complications later on. So they have a relatively good, success rate in non-inflamed eyes, especially those people who've had recurrent corneal transplants that just are failing because of immune reasons, like they keep rejecting the cornea.
Okay.
When you add in ocular surface disease, that the success rates can go a little lower. Fortunately, but especially in diseases that have an issue with the conjunctiva. Fortunately, Aniridia doesn't have an issue with the conjunctiva, but there's still a lower, I think, success rate compared to like just if someone had a reason for the or increased rates of rejection with a regular transplant. To answer some a little deeper into the question in terms of percentages, we actually did a study with when I was a fellow with Holland, looking at analytics in K-Pro and the outcomes, looking at because really what you want to know is what are the longer term outcomes?
Right.
Because initially, most people will do well with a K-Pro, keratoplasties, I always say an abbreviation for ease. Once you
Absolutely.
put one in, it's a pretty quick turnaround in terms of visual improvement. So there's a high chance of initial improvement. So we look at, did they improve by more than 2 lines of vision? And at 6 months, 74% of patients had improvement.
It's pretty impressive.
But as you follow these patients, by 5 years out, which was our mean follow-up, the rate of success, if you want to say that, is 2 lines of improvement was 44%. So it dropped pretty lower than
Significantly.
50%, and it was mostly due to glaucoma progression or there's this underlying inflammation that can happen with aniridics. And actually, Dr. Freeman was part of the group that with Holland that described Dr. Holland that described the anaerobic fibrosis
Fibrosis.
syndrome,
Yeah.
exactly where you can when you have some of these multiple intraocular surgeries or devices that can touch the maybe where the root of the vessels of the iris would be, it can drum up inflammation in your eye, and you get these membranes and lead to more chances of um, loss of vision, detachments, things like that. But there can also be glaucoma progression and then inflammatory damage to the optic nerve. Those are sort of or reasons for decreased vision over time. Even Montreal had probably the second largest cohort when I was looking at these studies.
Oh, okay.
In terms of follow-up, they had about almost 30 months of follow-up, and they do a good amount of K-pros there. And their rate of success was, in terms of visual improvement, was about 65%.
Hmm. Okay.
Okay. Retention rates. So not everyone can maintain the K-pro. Sometimes because of melting, it can be lost. So retention rates between those two larger studies, longer term studies, was about 77 to 87%.
Okay.
And so that we're talking about the things that make them fail. It can, they are at risk for melting. So the cornea can melt around the optic. It is an artificial implant within the cornea, and
Yeah.
we tend not to like the cornea tends not to like some of these sometimes. Um, and so that device can extrude. You can be at risk for if you have defects or things like that, an infection or an ulcer there. That can then, and because you have an access way from the outside the eye to in the eye because of the optic, because it goes full thickness through the transplant, you can have a chance of endophthalmitis, which is an infection in the eye. These patients can also have, retinal detachments, glaucoma. They can form a little membrane on the back of the optic. So for those reasons, mostly because by the time I was arriving as a fellow with Dr. Holland, um, he was sort of leaning away from keratoprostheses, K-pros, especially the Boston K-pro, as his first choice. So he kind of avoided primary K-pros, and
Right.
we did this as a later procedure for people who maybe failed ocular surface stem cell transplantation.
That actually answers another one of my questions about when would you recommend it? And that's a great answer. Everything I've always heard is a K-Pro is great when it works, but when it's not, that's not great. So, um, are there any that you know of prosthetic corneas that are in the pipeline beyond the Boston K-Pro?
Sure, yeah, yeah, because
Are there
yeah,
advancements
obviously
coming up?
the Boston Cape Rose obviously has the longest track record. There's Alpha Core, which was from Australia.
Okay.
It's placed between a lamellar, so within the cornea type pockets in two stages. It seems like it had similar outcomes to the Cape Rose. It's been around for a little bit. I remember one of my attendants when I was even in residency had done one of these. And then newer ones are the Cara Clear Cape Pro.
Okay.
You have
Oh
this.
yeah.
Uh, it goes in the middle of the stroma, so the bulk of the cornea is a stroma, and you put it in the anterior to mid part of that. So you're taking the top part of this anterior scarring, and then it's this foldable piece. It's synthetic, and it's slid into this area, um, and it doesn't require a human corneal tissue carrier. And then there's the Cornete Capro, which is this synthetic corneal implant that uses this polymer scaffold that they're hoping that integrates with the cornea. It sort of overlies the whole area and is
Okay.
incorporated into it as well.
Okay. Interesting. All right, let's move on to the stem cell transplant. I think it's also known as the Cincinnati procedure. Is that correct? Or the the a KLAL, right?
Yes, yeah.
KLAL.
So there's
Um,
different. Go ahead. Yeah.
go ahead.
There are different types, like you're saying, and I try to remember based on the type of donor that there is. So
Okay.
um, there's keratolimbo allograft, which is the one that's a lot of times used because you may not have a living donor relative that might be a good candidate. Um, so that's using a deceased donor.
Okay.
So just like we get corneal transplant tissue from the eye bank, same thing with keratolimbo allografts. We use the same corneas, but instead of using the cornea from the middle, we're actually using the stem cells around that
Okay.
that are donated from a deceased donor. And then you have living relative conjunctival limbal allograft, where we take part of the conjunctiva uh, and go up and take some of their stem cells, and we make sure we're careful and only uh, uh, transplant only about 5 clock hours or less. That way we
Okay.
don't induce any issue with our donors, and we've been very careful as long as we screen the donors and take a conservative amount. We haven't had an issue in donors having a stem cell issue.
Okay.
And then we transplant that to the recipient. And then the Cincinnati procedure is where you have a combination of living relative tissue, and then we supplement it with keratolimbo allograft tissue on the sides from a deceased donor, so you get
Oh,
more stem
okay.
cells. But with the original keratolimbo allograft we were talking about, we actually use we use three halves. So we get two corneas and we use three halves of them. So
Oh,
we
okay.
transplant a lot of stem cells to try and help out the fact that that it's not as fresh tissue.
Okay. So Ryan here on the chat said, I don't have aniridia. Does that mean my stem cells could be used to help my biological 10-year-old son who does have aniridia someday?
Yes, yeah, exactly. We
Okay.
typically make sure that there's a reason why if we have a living relative donor, we often prefer that is because we can blood type match them. So as long as there's a blood type match, and then we can
Okay.
also try. There's often a HLA match, so a gene type match. Think about it that way. Where, for example, a parent is going to typically be at least a 50% match, about a 50% match.
True.
Siblings can be almost 100% match, possibly, and just lower rates of rejection, and that can lead to, in a way, less chance of or needing less immunosuppression on the back end, and higher success rates, less rejection, longer survival of the graft. And that does bring us to the point, yeah, we talked about these are typically, yeah, these are all going to be allografts, so from a donor other than yourself. And so Dr. Freeman mentioned this, where because the limbus is more vascular and there's more immune cells, you have to use anti-rejection meds, more like kidney, liver, and other transplants to decrease the rate of rejecting them. Fortunately, our patients in general are healthier than, for example, kidney transplant patients.
Mm.
We
True.
follow their protocols because that's the way Dr. Holland had sort of learned transplant medicine from the nephrologist. So we use their same protocols, but all those patients are on dialysis, and they're waiting to get a kidney transplant. They're pretty sick. They can be pretty sick patients.
Yeah.
Most of our patients, sometimes it's really just the eye that's that's their main issue. And so they're often healthier. They can tolerate some of these medications better. And we also run our immunosuppression at lower rates, so not as high immunosuppression
Okay.
levels. So
Okay.
that can be beneficial. We also don't have to have them as long. We follow the Cincinnati protocol, whereas as we, even after the first 6 months, we start to taper down some of the levels. And then at 3 years and up to 5 years, we'll start to taper down more and more based on as long as they're not having an issue.
Okay. Okay. Awesome. How young is too young to use the immunosuppressant meds?
So we actually published a paper looking at our pediatric population when I was
Okay.
with Dr. Holland. It was a group of about 20 eyes from different patients. Um, Pediatrics ranging from age 9 to 18. So I think that was the youngest. If you're asking what's the youngest, and we just like we manage in conjunction with a nephrologist, adult nephrologist for our adult patients, we help collaborate with a pediatric nephrologist,
Okay.
so at the children's hospital there, and that's one of the reasons why I think a lot of it, most of the time, we're having good success in terms of um, having people tolerate the medications, or we need to switch. If we need to switch, we work with nephrologists to find the best option for each patient.
Okay. Okay. That explains
Oh,
how
but
it was
I guess to answer
managed.
your question, the success rate would be, I mean, in that series, it was about 75%.
Okay. So that's a decent success rate. Um, what are the consequences of a failure in this case? We know that with a K-Pro, a failure can be very, very bad for the eye, right?
Sure,
So what are the consequences of a failure or a rejection in the stem cell transplant?
sure. We try to prevent rejection because we know that even if we have one rejection, the rate of failure increases. Um, the fortunate thing is this is all a service procedure. We never go into the eye with any of the ocular surface stem cell transplantation. So we don't risk those things as much, especially during
So it's less
surgery,
of a
but
risk to the
correct.
eye as a whole.
Exactly, just with the surgery. So, and now, with steroids and other things, there's possible to have glaucoma and progression of that. So, even though, so that may be a risk you might think about in the eye. But if the stem cell transplant fails, you've now just have a failed ocular surface, but you haven't lost the eye. With the keratoprosthesis, let's say worst case scenario, you have an extrusion or you have um, if you have an endophthalmitis where you have an infection in the eye, these are rare things, but it is possible to lose the eye
Okay.
or lose the vision from the eye.
Okay.
If we look at success rate or I think it's good to look at long-term
Mhm.
data, right? Because that's what you really care about.
Right.
How long is the graft going to live and things like that. So we showed we had a long-term paper looking at they had to have a minimum of 5 years of follow-up, and so the average was about 9 years, and so 73 to 81% success rate. And
Oh,
Aniridia was one of the better in terms of categories, in terms of success rate. About 70% had improved vision for overall, and then if you looked at just at the first stem cell transplant, at that mean followed about almost 10 years, right? About 62% still had a two-line increase.
okay.
Um,
Okay.
and that's almost twice as long to follow up compared to the K-Pro data I told you about.
Yeah, that's a long follow-up. That's great. Jean asked here, following a limbal stem cell transplant, what are the signs? So what do you look for in early signs of rejection? How do you treat early stages of rejection? And how far can it go before it cannot be stopped from rejection?
Sure. So you're looking for almost like an angry eye, right? So if there can be the most noticeable to the patient would be an acute rejection and an acute severe rejection. The eye gets red, the stem cell segment gets swollen and red. You start to have vessels that can grow into the segment or the cornea, and
Okay.
then the skin may break down. We might see a little rejection line on the skin, the epithelium of the cornea. We treat it with oral. A lot of this is different from what a lot of cornea specialists even use for cornea transplants, but we need to use a lot more oral medicines. So I'll typically have them on oral steroids, sometimes even admit them for IV steroids.
Mhm.
So a
Okay.
good amount of steroids there. We might have to adjust immunosuppression, make sure the levels are okay
Okay.
for example, the tacrolimus. I might give them an infusion of IVIG, which can help sort of
Mm,
as a sink to remove antibodies that may be
sure.
produced. Yeah,
Okay. Um, what are some reasons maybe that someone should not have a stem cell transplant?
sure. Some people might not be candidates, for the immunosuppression part, and
Oh,
there's
right.
other medical conditions that people have. Let's say they have a lot of heart disease or not well controlled diabetes, or they might be older and they might not handle the medications as well. They might have a history of cancer. Um,
Oh, sure.
and when you have immunosuppression, sometimes the rate that's a rare thing. But if you already have a cancer, that could increase the risk of your cancer having an issue.
Sure, sure. Okay. Um, so I think we're kind of covering this, but Laura from Ohio had said, is a cornea stem cell transplant the only option for limbal stem cell deficiency right now, or is there anything else?
So there are some reports of aniridia with allogeneic CLET, so that's cultivated limbal epithelial transplantation. I was saying that that's where you can take a small sample of another donor, and in the lab you expand them out on on amniotic membrane or other type of culture, and then you transplant that onto the surface. And so
Okay.
you've transplanted a bunch of stem cells onto there. The short-term results seem are decent, but long-term it doesn't seem to it doesn't hold up as
Oh,
well in
okay.
my opinion as more of these traditional the keratolimb allograft or the living-related contractile allograft. Same thing for Comet we talked about is where they take oral mucosal,
Hmm.
but then you're having to look through that oral mucosa and the vision
Right.
potential might not be as much because it can be slightly hazy compared to corneal epithelium. And then there's just not good long-term data compared to these other procedures. So,
Okay. Before we move on from the stem cell transplants, I wanted to ask, you did your cornea fellowship under Dr. Holland in Cincinnati, and now you're associated with the Holland Foundation for Sight Restoration. Can you tell us more about this foundation and some of what you guys are trying to accomplish?
sure. No, I think it's great that Dr. Holland and his board are trying to expand the knowledge to other surgeons and create a network of stem cell transplant surgeons that can that can offer his procedure essentially or his technique and protocol that he's developed over years to other people around the country. He's also had people fly in from all 50 states to see him, and some that can be taxing on patients as well, not just his waiting room. Uh,
Yeah,
in terms of the cost of travel and trying to, if we can make it so that some people in other areas of the United States can provide similar services, I think that's always good for patients. And so we're trying to, I'm actually am part of uh, the board there in terms of heading up the education committee there. And so we hold a meeting once a year. We're going to have it in November, so mid-November this year, where we've invited other. I've actually gone out and try and find, who else is performing these procedures throughout the U.S. and trying to associate all of us together to have, better practices, right? The more we communicate and learn, we can learn from each other. We can troubleshoot, and it's just better for patients overall too. And then to form that network so that I know that if one of my patients is traveling somewhere, then I can and they have an issue, like you said, if they notice, oh, I
right.
think I might be having a rejection, I know I can have them, and they can confidently see that surgeon potentially to address the issue acutely, and then come back to me or something like that, which is always a good thing because like we talked about, not if you there's not a lot of surgeons that see these types of transplants and
Right.
can manage them as well.
Right. And I know you mentioned that you're setting up kind of centers of excellence. That really is what you're trying to do
Yes,
in
yes,
multiple places around the country. And one of them is with you, right, in Virginia, I believe.
yes. Yeah,
And you mentioned there's a few other states where they're trying to set those up as well. Is that correct?
sure. Yeah, the first two official ones will be or have already started at University of California in Irvine with Dr. Marjan Farid and her team. So she's got a few doctors around her that are performing it. And
Okay.
then up in Mass Eye and Ear in Boston with Dr. Thomas Dolman and his team.
Oh, sure, sure. Okay.
Um, they're excellent as well. And then obviously we have Ali DeJillian in Chicago, Clara Chan in Toronto, and um, some other people, for example, that provide services. Also, so in Italy, actually, my co-fellow Enrica Sarnicola
Okay.
does this. So if you're in Europe, she's very skilled at this. And
Okay.
then um, there's some other doctors that are performing the procedure, and hopefully expanding them and providing the resources to do more of these. So I'll probably have a longer list of names in the future.
Oh, that's great. It's exciting to know that others are, um, learning from Dr. Holland. And like you said, it's a whole lot easier to go to somebody nearby than it is to travel to Cincinnati, for instance.
Sure.
So that's fantastic. Now you mentioned something about a procedure called Bright Mem. I believe that's relatively new. Can you tell us more about that?
Sure. This is mostly because of the work of Joshua Ho at University of Minnesota. Uh,
Okay.
and he actually does a good amount of stem cell work as well. So he's actually great. I've known him for a while. Um, but brain mem, and then the type of procedure is called Descemet's membrane anterior keratoplasty, is where they've taken Descemet's membrane, and then it's decellularized to their technique, and then it's placed on top of the ocular surface. Typically, that's the layer that's on the back of the cornea. So Descemet's endothelium are sort of this complex on the back of the cornea. But they found that in studies that the front side of Descemet's membrane has a bunch of proteins that mimic the limbus and stem cell area of the cornea, and they're actually not in the central cornea. Um, and so, if they place on this on the cornea, it may act as a scaffold or a substrate to allow these skin cells that we're talking about to grow onto the cornea better.
Okay.
I've been doing it for a couple of years, and I've used it for persistent abrasions or erosions. People have sometimes chronic pain, and I perform this, and then they've been pain free for since I've done it, which is amazing. Also for conditions such if there's stem cell deficiency,
Okay.
um, it works best probably in partial stem cell deficiency because
Okay.
remember, so it does not provide any stem cells. I think that's the biggest thing to remember about it. It doesn't provide any stem cells. It's just acting as more of a substrate or a scaffold. Um, Amniotic membrane can also act as a scaffold, and
Okay.
that's been what we've used before that as a way to get skin to kind of grow over the cornea. But the beautiful thing about bright mem is that the Descemet's membrane is it's transparent.
Ah,
It's got a
okay.
little more and actually resists degradation better than the amniotic membrane. Amniotic membrane will dissolve typically
Okay.
unless it's incorporated with skin on top of it, epithelium on top of it. The but if you try and digest it in the lab setting, it will within hours amniotic membrane will disappear. But even after 24 longer hours, even with these digestive enzymes, the bright mem will persist, which is nice. And I have patients that are out a couple of years, and you can still see the bright mem if it's depends on how it's
Interesting.
incorporated.
So that it sounds like, if I'm reading or hearing correctly, it sounds like that's kind of a good option for somebody who maybe isn't a candidate for the stem cells, or maybe who, is just having a lot of pain, that kind of thing. Is that kind of when that would
Yeah,
be
I
a
think
good option?
this is a good thing you bring up. Yeah, so where in the algorithm, right?
Right,
Do
right. Like
we
where in there do we do
Yeah.
that one?
So after you have your medical management, I think that it's actually good early on. Um,
Okay,
so again, when there's more partial stem cell deficiency, that's where Josh has used it he actually has an Aniridic clinical trial that he's been
okay,
doing. That's one of his criteria. Or people who, persistent defects, abrasions, and you're trying to close those defects. And that's where I've used it, even if they have
okay.
total stem cell deficiency, I've used in those, and I've had one Aniridic that's done great, like I said, for over a couple of years.
Oh, that's
Maybe
fantastic.
he used to have more chronic erosions. I think with that membrane, he's only had one in the last couple of years. So that's
That's
been great.
fantastic.
Um,
Um,
if I just describe the procedure, so it's a little different. You remove the scar tissue and vessels and everything on the center of the cornea. And then you place the cornea on top, you peel it off, and you have this membrane that's left there, and you smooth it out, and then you place some tissue glue on top of it. You place a contact lens for healing on top of that to let the skin kind of grow in there.
okay.
So.
Okay. That's very interesting. Somebody asked, how can I find out more info and read about this Bright Mem procedure?
Sure. So there's a website with through the company Bright Star Therapeutics. I should mention that just so that we're all clear, I have consulted for them.
Okay.
So we have all the financial disclosures out there. But they have a website there, and they can it describes the procedure, gives you pictures of it, and then shows you some of the uses. And
Okay.
there's actually we're still a little in the find out where it's best used for and what type of conditions. I've
It's
told you
early,
where
right?
I found it's
So,
best. Yeah. And then, like I said, we should mention that so it's a lot of sort of case reports here and there, but then also Dr. Ho has had an ongoing pilot clinical trial for Aniridics where he's had people with partial stem cell deficiency, um, or they've had total stem cell deficiency and chronic abrasion. And
okay.
he's had noted for those people improvement in keeping and healing the abrasion, sort of like I noticed. And then uh, he did have overall, he's noted over his patients some improvement in vision as well as less central vessels, which has been
Okay.
nice. It may act as a little barrier, and so it might. This is why I say it might be good in. Let's say you had uh, two eyes with anterior keratopathy. And you had a more severe eye, and usually we would wait till both eyes were severe until like the better eye would be severe until you consider a stem cell transplantation. But you might actually consider it earlier in that poor eye
So it could
with the
happen
bright
earlier
mem.
in the process
Yeah,
than it would
because
be with stem
in
cell.
general it has less risk. You don't need immunosuppression. There's not really rejection. So, um, but again, it's not a replacement for stem cell treatment, but it might be earlier in your algorithm to consider.
Okay. Yeah, that makes sense. And I think that kind of answers one of the questions, Marcia from Pennsylvania said, are there any alternatives to the transplant that don't require the anti-rejection? And the
Hmm.
answer is it's not really an alternative, but maybe earlier in the process might help.
Yeah.
Um, depending on the situation, right? We are running out of time. Can you believe we've already talked for an hour?
Wow.
And there's so much more I would like to sit and ask you. Like I have a ton more questions. So I'm going to choose two more questions to ask.
Okay.
And then we'll probably have to wrap it up for this time, and I'll add these to the questions for Dr. Jajilian when I meet with him here in a while.
Sure.
Um, but I guess let me start with or finish up, I guess, with a couple of questions. One, are there any inhibitors, anything else you can think of that treats or slows the progression? I have Suhotro, who's a PhD candidate, who had asked that question. Can anything slow it?
Yeah, great question. Not that we're using clinically. There's a paper by Dr. Julian. Actually, this is a great question for him. He had a
Okay.
paper in 2020 that, in the pathway for the PAC6 expression, there was this MEP or MEK, sorry,
Yes,
um,
the MEK inhibitor.
inhibition in the ERK pathway. And if you inhibit it, then you could possibly uh, have some partially normalization of the eye development. Uh, that's a possibility, but it's still in animal studies.
Right,
Yeah.
right. Yeah, I know they're looking at a couple things like that might, but it's still in the animal study stage. Joel from the US had asked, are there any data or studies that show the effectiveness of the PROS lens? Is that different than the scleral lens that you mentioned before?
Yeah, Prose lens is even almost even better. It's even larger, it gets you more fluid on the surface. So
Okay.
just like I advocate for the scleral lens, I if you can get to a center that does the Prose lens and have an insurance that will help you pay for it, then I would definitely consider that.
That's also always a big deal, right? All right, I might have to save most of the rest of these, but I'll just ask from your opinion, do you think we're going to see cures and improvement in treatments, next 3 to 5, next 5 to 10 years? What do you think holds the most promise from the keratopathy perspective?
Dr. Julian is doing a lot of amazing work, and I'm glad you're going to have him next. He's been working on these mesenchymal stem cells for a while. I
Hmm.
saw a presentation at the World Cornea Congress like I think maybe 2 weekends ago, of his work and some of his colleagues from Dr. Soleimani. Uh, so these mesenchymal stem cells can help promote repair and things like that. They're these this population of supporting cells that help support the local stem cells in certain areas of the body. And the good thing is the eye is very accessible for them to add these cells to. So
True,
they can
true.
check the cells like around the conjunctiva, or they can get the factors that supportive factors that come from them and make them into an eye drop. And he's done some phase 1 and 2 clinical trials with especially the secreted factors. And while it doesn't completely reverse the stem cell deficiency, there's been some improvement in some of his patients with that. And not only that, it can also improve some of the some corneal scarring as well.
Mm-hmm.
He's noted, I think he had 2 patients with Aniridia. One of them
Mm-hmm.
did have a little regression in their late staining from it. So,
Oh,
but
that's
I
great.
think it needs longer follow-up and also
Sure.
more patients. So that's kind of exciting. But some of these other etiologies he was telling me about, like the with contact lens stem cell deficiency, he had some people that um, almost that reversed some or a good amount of it. So
Wow. Well, I'm very excited to talk to him here in a little
yeah,
while, and hopefully he can, start answering some of the rest of these questions about research and about things coming up. But that gives us a lot of hope about what's coming, down the pike. Really, that's pretty exciting. So thank you, Dr. Cheung. And I've already, kept you over. I promised you and everybody else that it would be about an hour. So I suppose we should wrap things up. I usually like to end, if that's okay, by reminding people, first of all, that yes, we are going to meet with Dr. DeJillian. He will hit the next phase of the iceberg and continue talking about the questions that we couldn't answer tonight. And I can't wait to hear more about the MSCs that you were just mentioning and some of the other exciting things that he's doing.
yeah,
Um, we will, as always, make a recording of this episode. It'll be available on the ANA website soon, kind of as soon as I can get it out there, really, is how that works. So be sure to sign up for any ANA newsletters if any of you aren't already signed up for that, so that you don't miss an episode, because we always send out an email. And before we leave, I would really love it if anybody who's willing could turn on their camera. It's always fun to see everybody who's here take a few screenshots, because it's encouraging to remember that alone we might be rare, right? But together we're very strong. So I'm going to change the settings here. It might take me a second to make sure that you can start your videos and whatnot. And hopefully we can all say hi. So I'm going to remove our spotlights so we can see everybody instead of just me and Dr. Chung. So feel free to go ahead and turn on your cameras and we'll wave at each other and say hi. Um, and if you have any feedback about tonight's episode, if you have suggestions for future topics, additional questions on the cornea that we can ask Dr. DeJillian, anything else like that, please feel free to email them. You can actually email them to focalpoint@aniridiana.org. That will come directly to me, so I will receive that. So yes, if anybody else wants to turn on their camera, they're welcome to do that. I'm going to take a couple of screenshots because it's just always fun to remember who all joined us. Um, it's wonderful to see friends, new and friends that I've had for a long time on here. Um, and I think I've got it so you're even allowed to unmute yourself if you want to say hi. But thanks everybody for coming. It's wonderful to see you all. And Dr. Chung, thank you so much. There was so much good information here. I'm still digesting a lot of it, and I'm excited, to get to know you better. I'm excited about these centers of excellence that you were talking about, and just the idea of how you're working on the education community to reach out and to make sure that you have kind of a standard of care when it comes to this stuff. That's amazing.
Well, thank you so much for having me. It's a pleasure to do this, and thanks for everything you do for this organization. So,
Well, it's certainly a privilege to be able to work with everybody here. It's one of the great joys of life. So thank you all for turning on your cameras. It's great to see you all. And I'll leave this up for just a minute. Um, oh, Patty said, will you please ask about the benefits or repercussions of Prolenza for pain? So I'm going to ask you that real quick before we sign off.
I don't typically like that for the cornea, unfortunately. At any time there's a irregular epithelium or possible a defect, I feel like it can melt, it has a chance to melt the cornea. So I shy away from the non-steroidal drops.
Okay, that is very good to know. Thank you very much.
Yeah,
All right, everybody. Thank you so much for joining us tonight. I am going to go ahead. Like I said, I'll leave it open for just a couple more minutes in case anybody has anything they want to add to the chat. And otherwise, we will see you the next time, probably late May. We'll be meeting with Dr. Jajilian. Once we have a date, we'll send out a save the date to everybody. So thanks again, Dr. Cheung.
yeah.
Everybody
Thank
have
you
a
everyone
great,
for coming and joining us.
yes, have a great evening, and we'll talk to you soon.
Sounds good. Take care.
Bye.